Hey everyone, good morning. Let me know if you can hear me. One person in. Alright. And we'll talk about well, I can't really talk about the exam until I validate it, but we'll see. Like some people might still be reviewing their answers if I had to guess. Morning. And the new PowerPoints are up on Canvas, so you should be able to see those. I think I published it. We'll check that. Yeah, it looks like it is published. My normal light's up, so I apologize if my face is being blasted out. Gonna start about 2 minutes here or so. Six people in. Of course, if you have any follow-up questions or anything, post them up on the sticky board or in the chat, and we can talk about them then. All right, it's 9 o'clock. About 8 people in, but that's okay. They can always catch back up for sure. I'm gonna go ahead and start recording here. Questions on the sticky board so far? Nothing as of yet. That's all right. So hopefully you guys can see the PowerPoints. I didn't see anyone confirm that, but I'll assume that you do see them. Otherwise, someone would say I can't see the PowerPoints. So I'm gonna go with that. Anyway, so this is where we're gonna finish up the all right, perfect. This is where we're gonna finish up the PowerPoints for cardio of the last section here. And then we probably won't get through all of this today, and then we will have oncology drugs, and then we'll finish up with GI. I don't remember how many last sessions we have left, but last time I did this, I think it ended up working out pretty well. So tests, I have 11, 6. 1, 2, 3, 4. We have 4 classes left, so that should be more than enough time to finish all that up. So I think that should work out pretty well. Giving me about an hour today. So anyway, let's go ahead and continue on. So first off, let's talk about heart failure. Benefits of Cardiology stuff we've already covered, is a lot of this is going to tend to be review for you. So like if you remember stuff about calcium channel blockers and beta blockers and ACE inhibitors, all that stuff still applies here, right? You still need to know all that stuff too. So if we're talking about drugs in here, if we're talking about ACE inhibitors, you still should know for this test coming up that like, hey, ACE inhibitors can increase potassium. Okay, hey, they can cause angioedema. You know, things like that are still things that I would like for you to know going forward with all these medications. We'll talk about a few new ones, but for the most part, with at least this section here, it's going to be some review, which will be, I think, fine for you guys. So anyway, you know, what is heart failure? Well, basically the heart is failing, usually from a ventricular sort of standpoint here. Very frequently, this is brought about by MI or some sort of ischemic heart disease, causing necrosis of the myocardial tissue, causing that deadening of the tissue. It gets fibrous, right? It's kind of like scar tissue, basically, and it doesn't pump very well. So that's very frequent. But we also see things like hypertension can also be a complicating factor here. You can even have like drug-induced reasons for cardiomyopathy. We'll talk about a set of drugs in the oncology section that very specifically they can cause a cardiomyopathy, and in fact, there's a lifetime max dose that you can receive because of that risk there, right? So lots of reason for people to have CHF. Even some heavy metals can do this. So for instance, like cobalt. You know, it seems kind of like a esoteric sort of thing there, but there actually was cases of beer at one point in history being contaminated with cobalt. People develop cardiomyopathies due to that, which I always thought was kind of fascinating. So like kind of oddball toxicity kind of cases there, but that was one of them. So anyway, so we can kind of divvy up heart failure into systolic and diastolic dysfunction, and so frequently these happen concurrently, as you're going to find here. But from a systolic standpoint, this is more on the side of the left ventricle having some sort of decreased contractility, whether that be due to loss of muscle mass, maybe due to ischemia. Also, chronic overuse of the left side of the heart can lead to hypertrophy. If you have chronic high blood pressure, it is more difficult for that heart to pump against that. And so as that muscle gets thicker and gets hypertrophied, it does not pump as efficiently, right? We want the ventricular muscles to be nice and lithe and be able to fill very well, and it gets difficult when it's stiff due to hypertrophy. And then you can also have some issues of dilated cardiomyopathies as well that all lead to that. But basically, you have a reduced ejection fraction. You're unable to pump out enough blood in order to, you know, basically sustain the body over time. And again, with heart failure, you're going to find that it goes through sort of peaks and valleys in terms of function. You can have cases of decompensation that occur due to things like their diet being off. That can be due to, you know, viral illness and all kinds of things there. Now, from a diastolic standpoint here, this tends to be due to more impaired relaxation of the muscle itself. And again, frequently this is due to also left ventricular hypertrophy. As I mentioned, thicker and stiffer ventricles cannot relax to allow for more efficient filling. And even ischemia itself can have some issues in terms of affecting calcium. And we'll look more into this when we get into the antiarrhythmics a little bit later on. But calcium is really important for allowing for the muscle to contract. But if you can't get rid of that calcium, it does not allow the muscle to relax, which will be a problem there. And so you can have people with just pure diastolic dysfunction, and they end up having sort of a preserved ejection fraction there. But overall, they're still going to have a reduced cardiac output. Okay. Now, for my purposes, I don't know that I'm going to get into the process of splitting hairs between systolic and diastolic function, but I want you to know that, so that way when we get into the drugs, you can kind of see what effects that they're going to have on either side of the equation there. Now, how does the body respond to the heart starting to fail? Well, it does things like trying to increase preload, right? Preload is the amount of blood getting back to the heart, afterload being the amount of pressure that the heart's having to pump against. Preload is usually a factor of blood volume. So for instance, if I'm holding on to more salt, I tend to hold on to more water, right? That's the same principle we saw with the diuretics before. As you hold on to more of that, you're going to end up seeing that pressure goes up, right? And you're going to end up seeing that more blood volume is coming back to the heart that the heart then has to deal with. We also see things like vasoconstriction due to activation of the RAS system, due to uptake of the sympathetic nervous system and all of that. And that's also putting more stress on the heart too, because it's having to respond to all that norepinephrine and on the beta-1 receptors to increase that contractility and that heart rate there. And all that overstresses the heart and causes further hypertrophy. And you can kind of see this is a sick cycle where as you get heart failure, you have these compensatory responses that ultimately make the heart fail worse, and then they have more compensatory responses, and it kind of propagates itself. And you can kind of see this here in this picture where in addition to having all these systems that tend to cycle back on top of one another, this is where we get a lot of the issues that patients complain about, things like dyspnea on exertion, or fatigue on exertion, having peripheral edema, pulmonary edema, all that kind of stuff is as a result of a lot of these compensatory mechanisms. So, and when we see these patients, you may be seeing them more on like the family practice side of things, more of the internal medicine side of things, where you're seeing these patients on the chronic span of their disease. But I frequently end up seeing these patients when they decompensate and they come into the ER, for instance. And this is usually due to things like lack of compliance with their medications or their diet. Hypertension can worsen these, arrhythmia, because again, if the heart's not pumping well to begin with, and then you put them into an arrhythmia, you can see that can be a complicating factor there. And then usually fluid overload can factor into this as well. So a lot of things that can precipitate a decompensation, and these can be pretty scary when they happen, because basically a patient's cardiac output takes a major nosedive. They can't perfuse very well. Lungs start filling up with fluid. It's just not a good picture there. So we'll talk about some ways to deal with that. Now, non-pharmacologically, the best thing for these patients is really to limit fluid and salt intake, and that's going to be difficult because, again, part of this compensatory mechanism is activating ADH, and ADH increases salt thirst, right? So, or salt hunger. So this is a tough thing for these patients to adhere to, but that is very good because it helps to reduce excess volume in terms of water on the body. It does not accumulate in the lungs, out in the peripheral tissues. And then if you can get them physically active, that is also going to be helpful. Again, these patients are having limited physical activity due to the fatigue that they develop there, because their heart cannot keep up with the body's demands. But the more that they do, the more functional status they should be able to regain, hopefully, to a degree. So let's talk about the pharmacologic therapy. Now, for these patients here, one of the big distinctions I'm going to make as I'm going through this is talking about what drugs are good for symptomatic management of these patients, which drugs are good for survival benefits, right? So you may put them on a drug that does not necessarily help them with their symptoms, but it's going to help them live for longer, and vice versa. And so it's important to know the distinction between that, because they may not always need the medications. They're helping with their symptoms if they're not having any symptoms, but they almost always need to be on the medications that are extending life, because based on the studies we have, we know that this is supposed to help them live for longer. So in terms of diuretics, as I mentioned, these patients are having an overabundance of blood volume. We want to get rid of some of that fluid, especially if it's accumulating in places like the peripheral tissues and, more importantly, the lungs. Because again, if your lungs are full of fluid, you're not able to really oxygenate all that well. Thiazide diuretics are good if you're treating their hypertension, but it's usually not potent enough to really get rid of significant volume off of most heart failure patients, right? So they may be on a thiazide, but it's not going to be sort of the mainstay for their to help induce diuresis for these patients. So that's where loops come into play here. So a mainstay of heart failure therapy, people talk about their water pills. They're usually on Lasix or bumetanide or something like that. But basically, this helps to decrease that preload. Okay. So you're decreasing the amount of blood volume coming back to the heart. You're also decreasing the amount of fluid that they're accumulating in the peripheral tissues and in the lungs. All very good, right? Now, not every patient, especially with more mild forms of heart failure, they don't always have to be on a loop, right? If they're not having issues of peripheral edema, they may not need to be on it. Some patients need this chronically just because they're, as they get more and more progressive, they're just very prone to holding on to all that extra fluid. So just something to note there. You may see it on a PRN basis, right? I may say, okay, I'm putting on a few pounds for the past few days. It's probably all fluid. Time to go ahead and take my water pill. Some people are just going to be on it around the clock. Just depends there. Now, note, it does not provide any sort of mortality benefits. These just help with symptomatic management, right? Help get the extra fluid off of them. Now, you may see patients who are on loops and thiazides at the same time. That's perfectly fine. If anything, they're helping each other out, because some patients can develop what we call loop resistance, and so thiazides help out with that. We'll talk more about that in the renal section next semester there. As I mentioned, not mandatory therapy, really only for symptomatic relief. and no evidence for helping out with mortality. So next up, one that is absolutely critical for these patients, they have to be on some form of RAS system inhibition, are going to be starting off with our ACE inhibitors. You can sub in your ARBs, no problem there if they have issues with cough or something. These are going to do a lot of things for us. These are going to help out with the preload, with afterload. They'll decrease sympathetic activation, so you have less norepi sitting there on the heart affecting it. And also one of the big things that it does is helps out with this left ventricular remodeling. Absolutely critical here because this can help to slow down their heart failure progression. Okay, doesn't reverse anything because we can't necessarily, reverse the ischemia and the dead tissue that's there in the heart, but we can help to slow down progression, help to decrease in the hypertrophy, the dilation that happens there, and overall decreases mortality. So this is absolutely critical cornerstone of therapy. And if you recall, when talking about things like MI, you would see that that was also a mandatory therapy after heart attacks, is to put them on an ACE inhibitor, because what's a frequent precipitant of heart failure? MI, right? So it makes good sense why we'd use them in this situation here. This is going to help out with their blood pressure. This is going to help out with them being able to tolerate exercise better for a longer period of time. They'll get less hospitalizations. They're living for longer. This is all good things, right? So make sure they're on some form of RAS system inhibition. If not an ACE inhibitor, put them on an ARB, right? So some issues we know that happen with ACE inhibitors too. Remember, you can see that acute impairment of renal function. This is typically in patients, again, who have pre-existing renal disease, so just be cautious with them. Certainly can see hypotension, especially if you're adding it on to other medications that may already be on for blood pressure. We talked about cough and angioedema risk, and the potassium here is going to be important too, because just on the last slide, what do we say we're putting these patients on? Well, probably like a loop diuretic, right? So, we already know that's going to be depleting electrolytes like potassium. Maybe if you put them on an ACE inhibitor plus a loop, they kind of counterbalance one another out. So again, this is why it's important to know what effects your drugs are having on electrolytes, because it's a very easy way to harm someone if you're not keeping an eye on it. And if you don't understand that, I put them on 3 drugs that increase potassium, 2 that decrease it, what's that going to do for the patient? If you're not looking, you're not going to be able to see it, right? So up next, we have our beta blockers. These are also going to be pretty much mandatory therapy for these patients here. Now, some of you may be thinking, well, wait a second. On the last set of slides, you were talking about beta blockers. The past couple weeks, you said that's contraindicated in heart failure. And so there's something to that. But again, we want to talk about this with some degree of nuance. And beta blockers actually are good for patients with heart failure. And it may seem counterintuitive because if you look at what do they actually do to the heart, well, they depress cardiac contractility, and these patients already have issues with contractility in the first place. So why would you put them on a beta blocker? Basically, what we see, and we have 3 basic beta blockers that are going to be kind of our go-to for heart failure. We have carvedilol, metoprolol succinate, which again is the long-acting formulation, and then bisoprolol. Those are the 3 that are really approved for heart failure. What we see is that if you can start them on really low dose beta blockers, and usually they're starting this in the hospital because you have to monitor them so cautiously, because again, this does decrease their cardiac output. This can precipitate a decompensation. That's why you want to watch them really close. Start them out in the hospital slowly over the course of weeks, months, maybe gradually increase their dose to what they can tolerate. And we do see mortality benefit, at least with these 3 here. So the patient will live for longer, because that kind of makes sense too when you're looking at it, because of the fact that you're kind of chronically taking away some of that stress on the heart, whether through the sympathetic nervous system, you're slowing down the heart rate, you're allowing the ventricles more time to fill. So overall, even though acutely, if you gave them full blast beta blockers, you would probably put them into a decompensation, put them in the hospital. If you were to follow the slow and low sort of approach, you will find that actually can increase cardiac output. So while it may seem counterintuitive, it does make a sense if you think about how we're doing this in a very gentle sort of way. So as I mentioned here, probably going to be in the hospital for most initiations unless they're pretty mild. And then start very low doses, slowly titrate up like 6 to 8 weeks or something. And you're always monitoring for worsened signs of heart failure. So you're looking at things like peripheral circulation. You're looking at peripheral edema, listening to the lungs to see if they're starting to get crackly and accumulating fluids. That sort of thing is what we're sort of looking for here. So as I mentioned with the benefits, they're improving their exercise tolerance. So they have, they can walk around their house longer before they get symptomatic. You'll see better hemodynamic improvements. This will help out with their blood pressure as well. And overall get an increase in ejection fraction. Because again, you're allowing the ventricles more time to fill. They can pump more efficiently. And overall, we see less mortality. We see less need for transplant, hospitalizations, all that good stuff. So very important for these patients in order to get some sort of beta blocker therapy. And again, those three that I mentioned are the three that have been shown to have those mortality benefits. So as I mentioned, first line therapy for class 2 to 4 heart failure, and basically patients with heart failure need to be on an ACE inhibitor and a beta blocker irrespective of symptoms, right? Or an ARB if you need to sub that in. Again, remember, if you have a patient with asthma, maybe something like bisoprolol or metoprolol is going to be better off than something like carvedilol. So still keep all those things in mind. You don't want to dump all this stuff from your your sticks of RAM that you have up in your brain. Don't dump it after the last test, even though it sounds tempting, because we're still going to need it for all the stuff we're learning here, right? Anyway, so moving on, let's talk about another drug which is new to us, even though I've probably mentioned it a few times already. This is digoxin. Digoxin actually looks kind of like a steroid, and this actually has some plant sources. I always like to mention natural sources for medications here, and digoxin actually comes from, and you can find digoxin out in yes, probably already dumped all that knowledge and you're like, oh, too late, but it's okay, you can pick it back up. Anyway, with digoxin, you can actually find it out here in Florida, the plants that this comes from. So if you're ever driving along, I drive on the 417 sometimes. You probably find this on other highways in Florida, but there's these plants that grow on the medians, and they'll like be pink or yellow or different colors, and those are oleanders. And actually, oleander is a big plant that digoxin-like compounds come from. You can also see like lily of the valley, foxglove, and plants like that. So pretty interesting. Obviously, I would not go and eat any oleander unless you had heart failure. Maybe that would work. I wouldn't necessarily trust myself as being not a very good botanist. But regardless, you can see it's sort of a steroid-like molecule here. We're going to see that it's very handy from a few different ways of treating heart failure, one which may not be quite as intuitive as what we might think. So what does digoxin do itself? Digoxin, which you may see called digitalis occasionally, basically inhibits the sodium-potassium pump. So this is going to segue into us talking about antiarrhythmics a little bit later on, but this is very important concept to get. So we're going to talk about cardiac physiology, electrophysiology a little bit later on, but how does the cardiac cells, how do the myocytes keep their resting membrane potential, right, between beats? Well, it does it with the sodium-potassium ATPase pump, right? And so if you recall, the sodium-potassium pump, very important for neuronal function, very important for heart function. It basically maintains resting membrane potential because it will shuttle potassium into the cell and sodium outside of the cell, right? Remember that on the outside of the cell here, your normal sodium concentrations are like 135 to 145. So this is pumping against the concentration gradient. Whereas with potassium, you have much higher intracellular potassium levels than you do extracellularly. If you think about the extracellular, a level of potassium being normal 3.5 to 5, it's basically the opposite of that inside the cell. So it's, again, pumping sodium against the concentration gradient, pumping potassium against its concentration gradient to maintain that resting membrane potential, right? That's why it requires ATP, because it takes energy to pump things against that gradient there, right? So what does that do for the cell? Well, basically what you're going to find is that you have an overall lack of sodium within the cell here, and this is actually going to stimulate, basically by having less sodium in here, you're going to be finding that this transporter here is an antiporter that is normally moving sodium out and calcium in, is not going to be as effective, right? Because there's low sodium levels here in the cell. Well, what would happen if I go ahead and inhibit this pump here? So I'm shutting down the activity of the sodium-potassium pump. What happens is sodium builds up levels within the cell, okay? Sodium builds up, builds up, builds up. And so now that you have a higher concentration in the cell, this antiporter is going to become more active. So it's going to kick sodium out and bring calcium in. This is the critical function for how digoxin is affecting the heart directly. Kicking out more sodium brings in more calcium, and as you have more calcium coming into the cell, that helps to cause that calcium release from the sarcoplasmic reticulum, and it allows for a stronger contraction. The more calcium coming into the myocytes, the stronger the contraction. That makes very good sense when you think about the actions of a calcium channel blocker. By blocking calcium influx with like diltiazem, you decrease contractility. This allows for more calcium in to increase contractility. Same exact mechanism essentially, just a matter of getting calcium in or out of that cell. So and that's a positive inotrope, right? So inotropy is that force of contraction. This is considered to be a positive inotrope. This is the old way we used to think that it worked, right? Because basically, if you had people with heart failure, you think, okay, let's go ahead and give them, they have poor contractility, let's try to increase that contractility, let's give them digoxin, and there you go. Well, we realize that's probably not the true benefits that we're getting from digoxin. A lot of it comes from what we call this neurohormonal effects. This is sort of a newer mechanism here, where basically it's helping to do things like decrease sympathetic activation, it's increasing parasympathetic activation. And if you think about what the parasympathetic nervous system does in the heart, you release acetylcholine onto muscarinic receptors in the heart, it slows it down, right? You can also help to resensitize the baroreceptors. Remember, baroreceptors detect pressure. In people who are chronically hypertensive, like a lot of CHF patients are, you're going to find that their baroreceptors get reset to a new normal. Whereas with probably most of you, 120/80 is considered normal. For someone with chronic hypertension, maybe 160/100 is considered normal for them. That's what the baroreceptors like, because that's just what they think is normal. Well, as you start to decrease blood pressure, those baroreceptors detect low pressure. They want to fight against that. So by using something like digoxin, you can help to resensitize that to some degree, okay? And it also helps to decrease the renin-angiotensin system. So another side benefit from that. So basically, it's doing the same thing. It's still blocking the sodium-potassium pumps in those baroreceptors, but overall, in the long term, that helps to reset their sensitivity. Also, because you're increasing amount of acetylcholine on the heart, that is decreasing heart rate as well. Kind of similar to what we saw with like beta blockers, okay? They're slowing down conduction and all of that. You're getting decreases in blood pressure, and overall, you're getting better cardiac contractility, so increasing cardiac output. So it sounds like it's doing a lot of really good things, right? It sounds like it's helping out from sort of a myriad of ways. It should be perfect for patients with heart failure. Overall, though, what you're going to find is that this is not going to be necessary therapy in most heart failure patients. There's going to be some downsides to it, as we're going to see here, right? So again, here's some other the neurohormonal changes, like remodeling and structural changes and things like that. But this is a narrow therapeutic index drug. This is something you have to watch pretty closely because of some of the toxicities we're going to see here in just a little bit. So notice here, I think most drugs you can dose or most levels, think like a vancomycin trough in micrograms per ml, for instance. This is nanograms per ml. So this is extremely small amounts of drug are needed in order to get the effects we're looking for. And going above that is going to lead to a lot of toxicity, as we're going to see here. And again, don't memorize the level. If I give you a level on a test, I'll give you what the normal is for sure. So don't worry about that. Again, this interpretation of levels is what I'm more concerned about than memorizing the numbers there. So what do we see when you give patients with CHF digoxin? We get improvement in their symptoms. They have better exercise tolerance and overall increased quality of life. And there is some evidence to show they have less hospitalizations, but unfortunately there's no determined survival benefit. So patients do not have to be on digoxin if they have CHF, but it could be a useful adjunct. It could be useful to add on to their regimen to get some better symptom improvements, okay? So as I mentioned, no evidence to slow down disease progression, and should be only added on after patients are on optimal doses of their ACE inhibitors and beta blockers, once they kind of have their diuretics sort of under control there, okay? Now, digoxin itself is an antiarrhythmic, and so it can be used for atrial fibrillation. We'll talk about this a little bit later on in the antiarrhythmic section. But if you had someone with AFib and heart failure, this might actually be okay. This might be good for them from a rate control sort of standpoint, which I'll talk about what that means later on. So, if you have a patient with symptomatic heart failure, systolic dysfunction, this can be something to add on. But again, get their ACE inhibitors under control first, get their beta blockers on board first, and then see if they still need some additional help. Digoxin may be able to provide that. Okay. So why are we hesitant to use this first line? Well, besides the fact we don't have any defined mortality benefits, there are a lot of toxicities with this. And so these are things you want to be careful or watchful for and let your patients know about. If they experience any of these things, it could be due to having too high of a level in the system here. So certainly GI effects, nausea, vomiting can be pretty rough on the stomach, especially in higher doses. But the visual disturbances are actually pretty unique to this drug. And this is not something you see really with anything else. So you can see some visual disturbances here, blurred vision and whatnot. But the unique thing here is something called xanthopsia, right? Xanthopsia, xanth is sort of a prefix meaning yellow. So they get sort of these like halos around lights, and they'll have kind of a yellow greenish sort of tint to them. And so this is like really classic digoxin toxicity. If you hear this, especially in like a board style question, or if you get, your preceptors pimping you for questions, this is a good thing to know because, again, it's very classic for digoxin. And in fact, even just a brief side story, I remember when I was in my first year of pharmacy school, I was in Jacksonville at the time, and I was at the YMCA there, and I'm not sure if you guys have ever been to a YMCA, but it's a popular hangout spot for elderly patients down there getting their fitness on and whatnot. But I recall very distinctly, in my first year of pharmacy school, you don't really learn much about drugs. It's a lot of pathophysiology and anatomy and things like that. But I remember overhearing a discussion with two elderly gentlemen were talking to one another, and one of them was like, "Yeah, I just started on this new heart medication, and the darndest thing, I'm getting these like weird, looks like a halo or something around these lights here. It's all kind of like yellow. I mean, he could not have been better describing it from a textbook than the textbook could have. And I think back on the moment, I was like, wow, that's really strange, because my ears were kind of pricked up for things about drugs, but I didn't know anything about the drugs. So, had I known any better, I probably would have been like, you should go see your cardiologist, because I'm pretty sure you got too much digoxin in your system there. But anyway, very classic for that. So xanthopsia is yellowing of the vision. We'll talk about some other drugs that can cause cyanopsia, which is a bluing of the vision, but this one is xanthopsia. As a result of that, having those higher levels, you can also see some central nervous system effects, things like fatigue, dizziness, confusion, even abnormal dreams. Because again, it's not only affecting sodium potassium pumps on the heart, it's also affecting them up in the CNS as well. And we know that's really important for normal neuronal function, right? So the biggest thing that's worrisome, though, is actually going to be digoxin toxicity on the heart. And so the most common thing you'll end up seeing with digoxin toxicity is probably sinus bradycardia, if anything, which makes sense based on its effects of causing increased parasympathetic activity on the heart, right? But you can really see a variety of different types of EKG changes for these patients here. You can see basically almost any type of arrhythmia can develop here. And so, AV block, you can develop, premature ventricular contractions. You can develop all kinds of things, especially when levels are too high. So you really want to be cautious with this, making sure you're monitoring EKGs before and after initiation to make sure that nothing funky is going on there. Now, what are my contraindications going to be? They are numerous, and so you want to be cautious with these. So, for instance, as I mentioned, AV block, bradycardia, all of that you want to be careful with. But really, anything that's going to aggravate, the electrophysiology of the heart is going to be bad with the digoxin, because you're more likely to see arrhythmias develop from this. So, for instance, hyperkalemia is something you really want to watch out for. And in fact, digoxin actually causes some degree of hyperkalemia too, right? Which makes sense because it's stopping those ATPase pumps from bringing potassium into the cell. So if they're not in the cell, then they're out in the blood, and you can actually measure that. So digoxin not only can cause hyperkalemia, but it's going to be contraindicated if a patient is already hyperkalemic, because that's just going to exacerbate that, right? Hypomagnesemia, hypercalcemia, all those things can increase their risk for toxicity. And also, it's not going to be great for patients with Wolff, Parkinson, White. So what do you do if you have a patient who's developing toxicity from digoxin? Is there anything you can do to reverse that? There actually is. And again, digoxin is something that is almost entirely renally eliminated. So it's important that, especially if you have patients with renal dysfunction, to watch out for that and make sure that you're adjusting their dose as appropriate. But what you end up seeing is that there is an antidote we can use for this. And again, I always like to point out antidotes. Good to know, especially from testing purposes, or if you have a patient who's having AHU toxicity, you want to know how to reverse it. But this is called Digoxin Immune Fab, or Digibind, Digiband. Sometimes you may see the brand name referred to this. This is actually an ovine-derived antibody, right? So this is not a monoclonal antibody, but it's still an antibody we've developed from an animal source. And so ovine, if you're not familiar, means sheep. So it's actually, we will take sheep and inject them with small amounts of digoxin to help them actually develop antibodies against it. And then we will then isolate out those antibodies and be able to give it to people, right? So just like you can have equine antibodies, you can have, which come from horses. This happens to be a sheep source. Interestingly, we, for whatever reason, people have less immunogenicity or less anaphylactic reactions to sheep proteins than to horse proteins. I don't know why that is, just seems to be the case here. But anyway, basically what this is an antibody, as I mentioned, that will neutralize the digoxin, will bind to it, and basically prevent it from interacting with the heart there. It's a very rapid way to reverse toxicity. Now, I've seen some patients who are, the digoxin levels are too high. Their heart rate's going like, 40 beats a minute. Blood pressure is really marginal. Give them the Digibind. Within like 5-10 minutes, they're back up to normal sinus rhythm. Good blood pressure, very, very effective from that standpoint. So good to know, again, if an antidote is available for a given drug. All right, so moving on, next we have our aldosterone antagonists. We mentioned these drugs before here. These do have some mortality benefits in patients who are more progressive in their heart failure. So like grade 3 or 4, you're going to see things like aldosterone and eplerenone can be used here for these patients. And again, this makes sense because it is helping to reduce the effects of aldosterone, and that is another component that affects the remodeling of the left ventricle. So this can help slow down that progression. Doesn't reverse anything, but definitely slows it down. It's important to know who not to give these aldosterone antagonists to. So obviously, if they're a little bit more mild, if they're still grade 2, you wouldn't use it there. Also, if their potassium is greater than 5 or the serum creatinine is greater than 2.5, you do not want to use aldosterone antagonists for those patients, right? Because again, what do aldosterone antagonists do to your potassium? They raise it up even further, right? If they have poor kidney function, their creatinine's above 2.5, they probably can't get rid of that potassium anyway. So these are reasons why you want to be cautious with that. And again, remember those common side effects, seeing more feminizing effects in male patients, seeing more masculinizing effects in female patients due to its partial androgen receptor activity, which we've kind of talked about. Probably had some test questions on that just recently, if I had to guess. Okay, so what else can we do for these heart failure patients? Well, we can provide some extra inotropic support. So all the other meds we've been talking about so far have been like chronic meds are going to be on taking for years potentially. These are a couple of drugs that we can use in the very acute phase to help us out with supporting the heart during a decompensation. So if a patient is showing up to the ER, extreme fatigue, dyspnea, the lungs just sound like they're just full of fluid. They put on, 10 pounds in the past couple of days, just a fluid. This is where, they're cold, distal extremities. This is where we can bust out some inotropic support to help the heart increase cardiac output, to help them supply blood to the oxygen to the body effectively. So 2 agents we have here are called milrinone and inamrinone. These are going to be basically drugs that inhibit this enzyme called phosphodiesterase 3. Now, if you recall, we talked about phosphodiesterase inhibitors in use with nitrates when we talked about angina, but that was PDE5. So drugs used for erectile dysfunction are PDE5. This is PDE3, so it is more specific for working on the heart. And so what these will do is actually prevent the breakdown of cyclic AMP in the heart. And by doing that, that actually increases contractility. So directly affecting the heart, increased contractility, can get that cardiac output up. You also are going to see too, this is good for patients who are hypertensive, because this actually helps to decrease arterial constriction, so that lowers the blood pressure, so the heart's not having to pump against such high pressures. On the venous side, it decreases preload. And again, these patients are typically fluid overloaded, so you have decreased blood volume coming back to the heart as well. So kind of helping from all sides of things. However, because these are vasodilatory, this probably not going to be good for a patient who is in heart failure decompensation where they are hypotensive, like they're developing cardiogenic shock. this is not going to be a case where you want to use a drug like this because this will lower their blood pressure even further, right? So not great from that standpoint. Now, again, we use these in the inpatient setting for very acute purposes. We don't use this for long term because we actually end up seeing increased mortality and risk for things like arrhythmia. So that's why we want to be very cautious with using these agents more so than just a few days, right? But what would happen if I had a patient who was, they're in decompensation, but they are hypotensive, right? Where I can't really use milrinone or anamrinone. This is where I can utilize drugs like dobutamine and dopamine. Dobutamine is a drug you might see more so used for things like cardiac stress tests and things like that. But it's a selective beta-1 agonist. Only affects the beta-1 receptor to increase heart rate, increase contractility. So that can also help out from a cardiac output standpoint. Maybe more often you might see is a drug called dopamine, which is, you produce dopamine yourself, but is useful as both a beta-1 agonist to increase cardiac output, but you can also use it to improve the actual blood pressure as well. It can act as a vasopressor. And a lot of it depends on the dose that you're giving. So giving low doses can help out with that renal function, but higher doses is where we're going to start to see increase in cardiac output, increase in blood pressure. And that's probably what you're going to be using this for those patients that are in decompensated heart failure, that are hypotensive and their cardiac output is no good, right? So that would be a good place for dopamine to be used there. Okay, so any questions on that so far? You guys have any questions over here? So someone brought up a question. It looks like a good one. Is it safe to combine a loop diuretic with digoxin for CHF patients, as one medicine will cause hypokalemia and the other leads to hyperkalemia? Can you do it? Yeah, absolutely. Again, this all has to go back to your monitoring, right? So say you have a patient who's taking, Lasix 3 times a day for, management of their fluid, prevent peripheral edema and all of that. And so, they're on their ACE inhibitor, they're on their beta blocker, they're on their Lasix, everything's looking pretty good. What is their potassium level like right now, right, when they're on their chronic meds? Because remember, not only is the loop decreasing potassium, but your ACE inhibitor is increasing it. Are they at a normal level of potassium? Are they at a level of 4, for instance? Normal level's 3.5 to 5. Let's say they're at 4. Would adding on digoxin put them at risk for hyperkalemia? Maybe, but it's probably low risk, right? Not like it would be if you were to put them on like an aldosterone antagonist or something like that. So see what they're at right now. If they were already at like 5.2 or even 5, I would probably be hesitant to add on that digoxin, right? Unless I can kind of figure out, okay, why are they so close on the borderline hyperkalemia? Are they getting it in from their diet? Are they getting, is a renal function poor, right? That may lead you to adjusting that digoxin dose anyway. So it's not a contraindication. You just want to be able to watch it and make sure to see kind of where the patient's at now at baseline, and then what the follow-up is when you add them on with that new drug, okay? So very, very important to be cautious with that. And again, I harp on potassium a lot, but the reason why that is because it's very easy to kill someone by screwing up the potassium levels, either too low or too high. Certainly too high is much more dangerous in the short term, but either way can cause significant arrhythmias for sure. So good question there. Okay. So at least I'm going to get started talking about the antiarrhythmics here, just to make sure we have enough time to kind of get through everything. If I finish up early, over the course of the next couple of weeks, might even have time for a little bit of review, which will be handy for y'all, I'm sure, because again, we have a lot of drugs we're covering here. So let's kind of just review normal cardiac electrophysiology. I'm sure some of you have had this already before, but I want to talk about it in relationship to medications to make sure we're all sort of starting out on the same page here. So looking at cardiac muscle, you can kind of think about it similar to, skeletal muscle to some degree, but the difference here is going to be sort of this this automaticity that it has, and a lot of this is due to what we call these intercalated discs that allow for transmission of these electric potentials, action potentials, throughout the heart very easily. And so what this means is it develops this sort of what we call functional syncytium, which is, again, a very fancy term you can use to wow your friends and neighbors. But basically what it means is that the heart functions as basically one big muscle, and it functions in a very sort of systematic sort of way to make sure that we are pumping blood efficiently. So, for instance, if the heart were to just everything contract all at the same time, if you had all the atria and the ventricles contracting all together, you wouldn't have any cardiac output because it just wouldn't be able to fill the ventricles. You wouldn't be able to pump things efficiently. It just would be no good. But the heart's really kind of designed pretty intelligently to allow for the atria to pump first. That then allows blood flow to go down to the ventricles, and the ventricles can pump. And so when you look at the electrophysiology, you can see how that's supported when you actually see how the electrical signal is being transmitted, right? So obviously we have our SA and the AV node. We know those are really important for setting the pace of the heart, right? So we call them pacemakers. Those are the cells that have the highest automaticity, SA node having the highest automaticity in terms of beats per minute. And what you see here is that as you start to send that signal down from the SA to the AV node, that spreading wave of depolarization causes the atria to contract. And then that signal is then going to travel down through the bundle of His, get down into going through the ventricle to the Purkinje fibers. And notice here too, like look how the heart's actually going to be contracting when you get down to the bottom here. Notice it contracts because the signal is going to hit down here first and then travel up. It's going to allow for a contraction from the bottom of the heart up, right? Which makes sense because which way you're pumping blood? In this direction. So again, it's pretty wild that the heart is designed in this way to allow for such effective pumping, good cardiac output through the way that's actually designed with these electrical fibers here, right? And so what you can see here in again, I'm not the expert on EKGs by any stretch of the imagination, but it's interesting to look at how the SA-AV nodes are functioning in addition to atrial muscle, ventricular muscle, to see how that actually is manifested on our EKG, right? So for instance, here you see the SA and the AV node kind of firing as pacemakers. We'll see how, notice their action potentials look a little different here, but notice the atrial muscles are going to contract first, which is, as a result, you can see that as a P wave on the EKG. And then as that action potential spread down through the bundle of His and all of that into Purkinje fibers, that's when you see the ventricle muscles start to contract as well, right? You can see the action potential develop here. See when you end up developing the actual QRS wave, right? This is the ventricular depolarization. And then as things start to reset and they start to repolarize, that's where you have your T wave, right? So it makes pretty good sense there. Notice you don't really see atrial repolarization because it's being covered up by the QRS interval there. So let's talk about the different sort of phases of the action potential, see what's happening within the myocytes themselves, so that we have an idea of what this is going to look like when we actually have drugs being introduced here, right? So basically what you end up seeing is that for cells like your typical ventricular myocyte, you're going to have, it's at a resting state. It's going to be sitting there usually around negative 90 millivolts and just sits there. And as long as no action potentials come along, it'll just sit there not doing anything, right? But as soon as an action potential comes in here, you're going to see that it's going to hit this phase 0 depolarization, right? So basically this is going to be affected by sodium channels. Sodium channels open up and allow for a very rapid influx of sodium into the cell that increases the electric potential, and you get this peak effect here, okay? Next, you're getting into phase 1, which is going to be there's a little dip, a little notch in the curve here. That is basically due to some outward flow of potassium. So positives are leaving, and a little bit of inward flow of chloride, which makes sense. You're losing positives, you're gaining negatives. It makes sense why it would dip down a bit. And then phase 2 is really important because this is where you have the plateau sort of phase here, where you have calcium coming in. Calcium coming into these myocytes is extremely important to cause contractions to occur, and I'll show you what that looks like in a moment. And then the other really important phase here is the phase 3, where we have repolarization. This is outward flow of potassium. So by having positives leaving the cell, the potassium leaving the cell, that allows for it to become back down to its normal resting membrane potential. And then phase 4 is maintained by the sodium potassium pump, right? So all that sodium that came in during phase 0 and all that potassium left during phase 3 is being rectified by the sodium potassium pump to get you back to resting membrane potentials, okay? So we can already see different places where our medications can be affecting these systems here, right? So for instance, we can see, well, maybe we can have drugs that block sodium channels and may affect that phase 0 depolarization. We've already seen drugs that affect the repolarization phase with potassium, right? We talked about macrolides, fluoroquinolones and stuff that block potassium efflux, cause QT prolongation. That's the thing we're talking about right here with phase 3. So these are all things we've seen before to at least some degree. So, and again, this picture looks a little funky because again, I'm not in like presentation mode. But again, this would, if you go into full presentation mode, you can see the different ions, kind of how they're flowing in, when those channels are closing and all of that. So I'm not going to belabor the point because I kind of talked about that in the last slide, but you can kind of see the animations there to give you a better sense, right? So another really important thing I want to talk about though is what we call the absolute versus relative refractory period, okay? An absolute refractory period basically means that when you're in that phase, there is no signal strong enough that can come along and activate another action potential to occur. So normally the absolute refractory period is going to be sort of in this early phase, 0, 1 to 2 sort of area here where the cell cannot refire off another action potential, it cannot contract again because it's in this refractory period. But towards the tail end here, towards the end, you're going to start to see during this repolarization phase, we get to what we call a relative refractory period. What that means is that the cell's still kind of resetting itself, it's not going to fire off again, but if a strong enough signal comes along, that could then reactivate it to cause another action potential to fire off. Okay, so this is important because what if you had a piece of cardiac tissue that was ischemic? It's not really conducting electricity all that well, but was basically causing an ectopic foci, right? Causing an aberrant rhythm to occur there. You can have things like that cause an arrhythmia to develop because it's hitting these other myocytes that are in this relative refractory period. So we can develop things like VTAC and VFib and whatnot. So the important thing to know with this is that with the use of some of these medications, we can affect that refractory period. We can extend the absolute or relative refractory period to allow it to be more difficult for arrhythmias to develop, right? They can actually kind of decrease our threshold, or increase our threshold, I should say, for having an arrhythmia. So very important concept to understand is the relative versus absolute refractory period. And if I didn't do a good job explaining that, you can just let me know. I'll try to give it another go there. So those are the fast response cells. Those are the cells that only respond when they get an action potential coming in, right? We have what we call slow response cells too, and these are going to be our pacemaker cells. This is the SA and the AV node here, and we're mainly talking about. And so what you can kind of notice here is that this is going to be a little different because whereas with typical fast response cell like in the ventricles, its resting membrane potential is just flat, it just sits there until an action potential comes along. The difference here, though, is you're going to see that these cells have these leaky sodium currents. And so notice how there's a bit of a slant here. That's because sodium is slowly leaking in to these cells. And how fast that's occurring can dictate how fast your heart rate's going to be. So what happens is you have the sodium leaking in, and once you get to a certain threshold, at this point, then all these calcium channels are going to open up. So calcium is going to flow into the cell here. This is phase 0 of that, right? So now you can already see where calcium channel blockers might come into play here. But you can see how it's going to slow calcium influx. And then phase 2 is going to be, notice there's no plateau phase here, but during this phase and phase 2, you're going to see calcium current is going to be coming in. You're going to have some outward potassium leaving. And then for phase 3, during the repolarization, again, it's going to be outward potassium here, okay? And then to get back to resting membrane potential, sodium potassium pump is going to help out with that. And then you're going to see that leaky sodium channel start to take over again. So we can already see here too how things like calcium channel blockers could be affecting this, like non-dihydropyridines like verapamil and diltiazem can strongly affect this, can slow down the heart rate. We'll also see how beta blockers can affect this as well to some degree. Okay. Again, you can do this in presentation mode to see the animation for how all this is working. Again, just another pictorial example of how ions are flowing during these action potentials. So some principles I want to get into before I let you guys go for the day is that when we're dealing with antiarrhythmic drugs, it's really important if you can to try to deal with the precipitating factors that led to that arrhythmia in the first place. So what I mean by that is if they are having an arrhythmia because they're hypoxic, because they are, they were, say, in a fire and they weren't getting enough oxygen, then give them oxygen. If their tissue is ischemic because they have a blocked coronary vessel, then open that up with a balloon. Or if it's electrolytes, fix the underlying issue if you can. And then if you're still having arrhythmia after fixing that, then we want to figure out how do we want to treat this arrhythmia, and depending on where it's at, that may affect things, whether it's supraventricular or in the ventricles. In some cases, you may want to terminate that arrhythmia and put them back in a normal sinus rhythm. Some cases they may not be feasible, and we may just want to focus on keeping the ventricles pumping at a rate that is compatible with efficient filling and pumping. Because again, with like a supraventricular tachycardia, the patient may be tacking away at 180, and if the ventricles are trying to keep up with that, it can be very difficult, and they can tire out over time, leading to instability. But we'll look at some of the different ways we can manage that when we get into the drugs probably next week here. But overall, the other really important thing here too is that all antiarrhythmics themselves can cause arrhythmia. And so you have to understand those mechanisms for how they can do that in order to help mitigate that for your patient here, right? So be very aware that any antiarrhythmic drug can cause arrhythmias. You'll see the same thing with seizure drugs. Any anti-seizure drug can cause seizures themselves because, again, they're affecting the electrophysiology of cells in the brain, or in this case here, cells in the heart. And then the other thing to note here too is that the electrophysiology of the heart is a moving target. As time goes on, tissue changes. Tissue, becomes more, hypertrophic. You can see ischemia can occur that can cause some deadened tissue. You can find that things will change over time, so it's important to go back and readdress this stuff because antiarrhythmic therapy that works for them when they're 50 may not work for them when they're 60, for instance. And then, of course, looking at things like ischemia, this is very important because this can affect resting membrane potentials. It can affect conduction velocities, intracellular calcium, repolarization rates. All that can really be affected here. So again, this is why MIs are a common reason for people to develop arrhythmias because of these changes in these different bits of tissue. So little things to note with that. So I think I'm going to go ahead and cut it off there. We'll talk about our classifications for drugs next time. But think about that electrophysiology. Have a good understanding for the ion flow that's occurring both in your autonomic cell or the pacemaker cells, like SA and AV node, and also in the fast response cells, like in the ventricles and the atria and whatnot. So think about that. You should be well prepared for next week when we get back into this. Let's see if there's any other questions here. As far as the test goes, I'm going to go ahead and I'll check that out once I get the stats sent to me. So I'll see what that looks like, if there's any givebacks, if there's any missed keys, anything like that. And I'll give you guys an announcement to let you know the results there. Get your prescription assignment done. I think it's due Sunday, and I'll get the next one posted up for you guys, the last one for the semester. And then other than that, I think we're good to go. So if you have any questions about the exam specifically, you can just email me. But again, I probably won't be able to respond until I get the exam validated. So any other questions? If not, you guys are free to go. Hope you have a very good weekend. Someone did ask here, they said, does hypokalemia affect the mechanism of action of digoxin? It depends. So, why is the patient hypokalemic? That can be as a result of total body reduction of potassium. So say, for instance, with like a diuretic where you've been urinating it out, basically. Other cases, you can see a patient develop hypokalemia due to inward flux of potassium into the cells, right? Because when you measure a blood level, you're not measuring what's in the cells, right? So in the cases of if it's just being transported to the cells as a result of things like insulin, alkalemia, things like that, it probably wouldn't have a big effect there. In terms of hypokalemia, I don't know that you see a huge clinical effect, but theoretically it may lead it to not being quite as effective there. But certainly just know that digoxin will kind of bump up your potassium levels to some degree. But yeah, I'm not sure if that has a direct effect, but it's probably minimal, if anything. Okay. Well, thank you all for joining me. I hope you guys have a good weekend, and I will see you all next time.